So thank you everybody for coming to today's training. I'm Stephanie Dahlberg with the Bureau of Housing Supports at DHHS. I'm the co-chair of the Balance of State Continuum of Care Coordinated Entry Subcommittee. The Balance of State Continuum of Care is sponsoring today's training and the entire series with continued communication and collaboration with Greater Nashua and Manchester Continuum of Care. We're here today to receive community-wide training on coordinated entry. The training was developed and will be presented by the Technical Assistance Collaborative. Today will be a pretty high-level, quick, general overview of what a continuum of care is and what coordinated entry is. And again, we really appreciate you taking the time to come here today and hear what's going on. The majority of this will be in a presentation format. There will be time at the end for questions and answers. And with that, I will pass it over to our presenter, Doug, from the Technical Assistance Collaborative. Thank you.
Great, thank you, Stephanie. And if you could keep an eye on folks coming into the room, I'm going to go ahead and close my participant panel so I can focus here. So thank you, everybody, for joining. Welcome. I just want to first say how much we appreciate you taking the time today. We know that everybody is quite busy all of the time, not to mention the fact that we are in the middle of the HUD's notice of funding. We're in the middle of a global pandemic. We're coming up on the holidays. There's a lot going on. So really appreciate your time. My name is Doug Tatro. I work for the Technical Assistance Collaborative. We are a TA provider that supports HUD and VA in different capacities for training and policy support. And I've been working closely with the Balance of State of New Hampshire over the past few months, looking at the overall continuum of care and some of the coordinated entry processes that we're here to kind of introduce today. As a side note, I do work in communities throughout the country, but I'm from New Hampshire and currently live in Manchester. So it's nice to be with you all in a local community to me. And I have some family history in homelessness. My father was homeless for quite a long time. He actually passed away this year, but I've seen the effects of how this can affect families here in New Hampshire and in different parts of the country. And I'm happy to be here to support you all in your work. Today is really an introductory discussion or overview of coordinated entry and the continuum of care and some of the main concepts. So from some of you, today's session, which is going to be about an hour, we might run a little long, will be sort of recap. For others, there's going to be a lot of new concepts that you may hear today, and I'm sure some folks right in the middle of those two ends of the spectrum. We're hoping that we can find some time at the end for questions in the chat. We only have about an hour scheduled. We might run a little late. We are recording this session, so if you have to hop off early, or if we do run a little bit late, you'll get that recording link to you within the next couple of days, as well as the slides from today's presentation. So let us know if there are questions. We may or may not be able to get to those right away, but we are planning additional trainings over the next number of months like this, some of which will be more interactive than today, which is going to be more presentation, and we can make sure that any questions that do come up or concerns that are brought up during the discussion, that we address those in future sessions or other meetings that folks have. So what I'd like to do as you're starting to get settled here is just take a quick poll to figure out where folks are at. So if you should be able to see a poll up now, and Stephanie, let me know if you don't. But what we'd like to know is your overall level of comfort with the concept of coordinated entry and assessment. Are you a pro? Do you need some practice? You've got a sense of it. I don't know what this term is. It's an anonymous poll. Let us know so we can get a sense of where folks are at. It just gives me a little bit of basis as I jump into what we have, which is a fairly dense set of slides. So I'm going to leave that poll open for another 10 seconds or so. So please go ahead and indicate your level of comfort. It looks like those results are coming in now. We've got about 90 or so, 80 or so folks that have responded. So keep going there. If you haven't yet, we'll give it another just few seconds here. I'm hoping I can broadcast this poll, but if not, I'll recap it for you. So it looks like of the folks that have responded, about 15% of you really feel like a pro. A good healthy, just under half of you feel like you could use some practice, but you're getting there. About a third of you have a general sense of what coordinated entry is, and there's a few folks on the line who hadn't heard of that term before. So I'm going to share those results, and you can see here, this is sort of our level field. This is our bell curve as we get started. So today's discussion is going to be a general conceptual overview of the continuum of care and coordinated entry and what all that means and what's required of it. We are not going to talk specifically about the protocols or the policies of the New Hampshire continuums of care. We want to get a sort of what is the big picture that HUD and communities are trying to achieve with coordinated entry. And then in future sessions, we'll be more focused on the actual practices here in New Hampshire. I also want to note that we are continuing to work on other aspects of this that I'll get to later around assessment. So I'm going to stop sharing that poll and go ahead and close it, and we're going to dive right in. So I appreciate everybody filling that out. So what is the continuum of care? So what HUD has established, and what was established under what's called the HARTH Act, is this idea of a continuum of care, or in our layman's terms, the CoC. And every community in the country is required by HUD, or any community that receives HUD funding, which all of the ones in New Hampshire do, to establish a continuum of care in order to receive that funding. And HUD outlines basic governance and structure for how a continuum of care is operated. And it requires that the CoC program, which is the NOFO funding that some of you are applying for now, the primary rapid rehousing, transitional housing, and permanent supportive housing programs that are funded by HUD, collaborate with our emergency solutions grant partners, or what used to be called emergency shelter grant partners, and that we are establishing a collaborative process that includes all of the interested stakeholders who are charged with planning and implementing strategies and goals to end homelessness. So this is you. Everybody on the line today, I would venture to guess, is an interested stakeholder in trying to end homelessness. And so our continuum of care is not a single entity or organization or person, but rather this consortium of interested parties that represent the different relevant organizations within the area, folks that run all different aspects of homeless services, but also interested parties that may not be necessarily connected to homelessness directly, but are part of this overall effort. So institutional care settings, prison settings, mental health systems, and healthcare systems. So when I refer to the CoC, I'm not referring to the state or to a single person or a single sort of entity, but rather the collective body of stakeholders across the state or within the local continuum. So in the state of New Hampshire, there are 3 continuums of care under HUD geography: the Manchester Continuum of Care, which is the city of Manchester; the Greater Nashua Continuum of Care, which is Nashua and some surrounding communities; and then the remaining balance of the state is the Balance of State Continuum of Care. So our state here is divided into 3 CoCs, each of which is comprised of the various stakeholders who are governed by a governance charter that are organized under this idea that we're building a system to end homelessness. And the CoC as a whole has a lot of say in how we make those plans realized, from governance to overall monitoring of project level of performance, to establishing a coordinated assessment system and written standards for how people are prioritized and referred into services. The CoC also designates and helps to operate the Homeless Management Information System, which is the primary data collection system for all things related to homelessness in that geographic area, and overall planning around homeless services. And so,
hey Doug, can I pause you for a second?
Yeah.
Sorry.
Yeah.
It looks like you're sharing your screen, so we can see the next slide and the notes and all of that. We can't see the presentation.
Got it. Does that help?
Let's see, I'm not seeing any change yet. Hold on.
All right, check this out. I'll fix that. Give me 1 second, everybody. I apologize.
Thank you.
Let's see if this helps us here. that better?
All I can see is your Windows screen.
Okay, one second. How about that?
Looks
There
great.
you go. Yeah,
Thank
you're in
you.
presentation mode now.
We're back in action. All right, thank you, Stephanie. I appreciate it. So there are 3 COCs in the state of New Hampshire, but what's important, I think, for us, and is sort of distinct from other states and communities across the country, is that many of you overlap. The similar organizations providing services in Nashua may be providing services in what we call the balance of state. Similar organizations that are operating in the balance of state maybe also be operating in the city of Manchester. So this presentation is going to talk more generically about how coordinated entry works, and we're going to sort of apply that as a blanket introductory session for all of you, regardless of which continuum of care you either reside in or work in or your services are provided in. But the general point here is that the COC is meant to be this larger body of stakeholders who have duties and responsibilities under HUD's rules to plan for and execute strategies to end homelessness among all populations. So we work together to create a system that includes our outreach processes and engagement with folks who may be either in encampments or outside or are receiving other services in the community, how we make sure that emergency shelter and housing are coordinated, and thinking about how we can prevent homelessness amongst families and individuals as well. So across what we call HUD's interim rule under the Hearth Act, which if anybody likes some nice light bedtime reading, I invite you to read the interim rule for the COC program. There are many requirements of the continuum of care, and many of those requirements fall to what we might call a collaborative applicant. But today we're going to focus primarily on our coordinated entry process, the system of access, of assessment, of referral, and prioritization into our limited housing portfolio. A really key element to this for everybody on the line is that HUD requires that the continuum of care programs, the programs that are funded by HUD in the NOFO, are coordinating with our emergency solutions grants programs around how we target our resources to best meet the needs of our community. And I would advocate, and I think that the goal here is that regardless of the source of funding that you may receive for your particular project, whether it is city funding or county or state level, or it's coming from the federal government, whether it's VA funding, that all of us are part of this system, this consortium of interested parties who are going to work together to end homelessness in the best way we can with the limited resources we have and the local constraints that we have to work within. And so even if you are not funded by HUD, or you don't have federal grants, or you're a privately funded organization that's providing services, you are strongly encouraged, both as a matter of sort of philosophy and a matter of practice, to be active participants in the different processes that the continuum of care has laid out. And one of those will be around coordinated entry. Coordinated entry is a concept that was first defined under the Hearth Act back in 2012. And across the country, communities have been trying to build up what we call their coordinated entry or assessment systems. And what the basics of this means is that we are establishing a system where there's an initial comprehensive assessment of needs for individuals and families requesting assistance, that we cover the full geographic area, and that anybody who is in a housing crisis is able to access this system where we're going to be able to identify what their needs are and how we can best assist them, again, within a finite resource environment. So as an illustration or sort of a discussion of general coordinated entry, what we're trying to do is go from an old system, which was first come, first serve, regardless of an individual or family's vulnerability. We were going to serve the folks who showed up first because that was fair. And what we did for about 40 or 50 years in this country, since about the 70s when the homeless crisis really began to unfold, is we failed at ending homelessness, right? We were unable to be strategic in how we use a finite bucket of money or bucket of housing resources to meet the needs of the most vulnerable people in our community. So what we are trying to establish, and what HUD has required us to establish, is this housing crisis approach where folks are prioritized for available resources, not based on who showed up first, but based on who is most vulnerable in their homeless crisis, who would have the most challenging time getting out of homelessness on their own, or have the most detrimental and even deadly consequences of being homeless moving forward. And so what we recognize is that we need to make sure that all of our programs and all of the resources that we have are working toward that similar goal. It is demonstrably true that in order to end homelessness for all, we must first end homelessness for those who are most vulnerable and who have the highest level of needs. In order to do that, though, we also have to balance the fact that we simply don't have enough resources or the right type of resources necessarily for what we would ideally like to connect people with. And if you'll excuse me, I have a little cold today, so if I have to cough or sniffle, I apologize. I know it's loud in your ears. One of the key features of an effective coordinated entry system is having effective programs that can meet the need of the folks that are facing your project. So for instance, in an effective coordinated entry process, we are not able to necessarily isolate significant resources to people who do not have higher levels of need, because we have such a large group of folks who do have significant vulnerabilities based on whether it be mental health or substance use or lack of income or history with evictions, or maybe they're part of a historically disenfranchised racial group, or whatever it might be. We have these cohorts of folks, or these folks that really are in most dire and urgent need of our assistance. And in order for us as a community to come together to meet the needs of those folks, we often have to sacrifice on the other side. And that means that our programs have to operate as optimally as possible. And we're going to talk about this a little bit later in terms of how different projects are connected to individuals needing services. But right now in the state of New Hampshire, there's not enough permanent supportive housing to house everybody for whom you think permanent supportive housing is the best option. And so we as a community and as practitioners have to then identify those other resources like rapid rehousing that we can better use to serve higher need and higher vulnerable populations. So in general, coordinated entry assumes that we don't have enough money or housing to house everybody. And whether or not we should have enough money is another question. I think we'd all like to see more money and more housing, and we'd like to see a lot of affordable housing resources come into our community, but that's not within our control. So we have to employ these different creative approaches, things like effective targeting for prevention for folks that we can keep from becoming housed, things like diversion and problem solving for folks who have recently become homeless and may have other avenues or other options within their social network or family network that allow them to not be living on the streets or shelter in their car today, and really focus our strategies on a housing first client driven approach that really focuses again on those with the most significant housing barriers. Excuse me. You can see here sort of the highest level picture of how we might discuss coordinated entry, right? We have folks that are coming in from community settings. There is a diversion or coordinated process where they're accessing initial services, whether that be street outreach or shelter or the 211 line. They are engaged in this effort to divert them from homelessness, to explore other family or social or natural networks in their community, or to mediate with their landlord to keep them from losing that apartment they have, or to connect them with family and friends in another part of the state that are willing to take them in and make sure they don't live in their car on the street. We are recognizing that that group of people that have those alternatives may be limited. So we are providing that emergency response, whether it be an emergency shelter or a hotel motel voucher or some sort of place that is safe today. And then we begin to understand who we can serve with our rapid rehousing dollars or our transitional housing dollars. And of that big universe of folks who are in housing crisis, who are we going to need to be able to isolate our finite, limited, high intensity permanent supportive housing slots for, because we simply do not have enough of them, right? So there's a system designed to help us use our resources as effectively as we can within the constraints that we face. And sometimes the use of those resources isn't necessarily ideal, right? But we break down this idea of coordinated entry into 4 primary elements. And this is all, the elements here identified by HUD. There's a guidebook online. This is not just Doug Tatro making this stuff up. There's a lot of resources beyond the 60 or 75 minutes we have here together to continue to dig in on this. But we break this down into 4 primary components. Access. So how are people actually approaching you all or the system that we've designed in order to let us know that they're in a housing crisis? How do we find those folks? How do they have access to even the assessment that we're going to use to try to identify what type of resource might be able to serve them? As people are accessing those emergency services and those intake services, we have a process of phased assessment where we're gathering information over time that help inform how we might help this person end their homelessness. Then, based on our finite resources, we have to prioritize. We have to recognize that there may be 100 folks at your door, but you only have 10 beds, or that there are 100 folks that we know would likely benefit from permanent supportive housing, but we only have 15 slots. So we have to figure out how are we going to prioritize what is sort of at its core an unjust and unfair process. How do we then prioritize the best we can to make sure the limited high intensity resources that we operate are going to those who need them, and that the other resources that we operate can meet the needs of those who are in those higher vulnerability categories, but for whom PSH isn't available. As we identify and prioritize and we understand where we need to focus our finite resources, we are then able to refer into projects and ultimately house people. So starting with access. In New Hampshire, you might see some of these terms that I put on the slide here. The 211 system, your regional access points, the emergency shelters in the community, both funded and unfunded, your mobile outreach teams or other teams that are going out into the community or going out into shelters or encampments or wherever it may be to engage with people who have lost their housing or are on the brink of losing their housing in the case of, in particular, the RAPS and New Hampshire 211. But we're really referring to what the experience is for people who are looking for services, right? That know that the coordinated entry process exists, that know how to contact emergency services. So within the state of New Hampshire, how do we make sure that if I'm going to lose my housing or have just lost my housing, that I understand how to engage with a service provider for at least that emergency point of contact and sort of the next steps from there. So the access points, whether it be virtual, whether it be phones, whether it be physical, whether it be outreach, are a critical role in that initial engagement with people who are in a crisis, who are in the worst day or month or year of their lives. And it is the most immediate response we have is at that access point. Access points for very many years have basically said, we're gonna enter a bunch of data about you. We're gonna find out what you're eligible for, and then we're gonna fill out tons of applications and send them off into the wind and hope that you get a call back, right? We're gonna essentially check your eligibility and sign you in for the night. What we're seeing now is this greater and greater need to employ more creative strategies that really focus on diversion and problem solving and connecting with people as human beings before we go along scoring people on a sheet or putting them on a spreadsheet, connecting folks with what opportunities may exist in their lives for safe options other than being literally homeless tonight. And so housing problem solving is this sort of term that HUD came up with that basically means rehumanizing that initial experience for folks, stop treating them like a checklist or a number on a spreadsheet, and really focusing on not how do we take you into our service and give you the bed for the night, but first, what is it that we could do to try to negotiate or help you coordinate a better option other than being homeless tonight? We see a lot of folks in the news and in the newspapers across the state, especially in the cities, talking about the encampments and talking about the visible sort of homelessness that are on the streets. What we forget are all these other folks who are in a precarious or crisis housing situation who also have other options that they need, that they could be explored if we're working with them, if we're engaging with them creatively at the front door of our system, if we're using that conversation and that client-centered approach to try to divert people on an ongoing basis, continuing to look for other opportunities other than the finite amount of dollars that we get from the feds or the state to create rental subsidies and supportive services. we have to reduce the inflow and pressure we have on the scarce resources that we have in front of us, because we simply don't have enough dollars and cents to be able to give everybody a housing voucher or a 6-month housing subsidy. So using these creative approaches is the first step in what we call a phased assessment approach. It is a skill set that is trained, it is trauma informed, it assumes that some people, not all, will have alternatives to their homelessness if we get creative with them and help them negotiate those alternatives. And it allows us to focus our limited housing supply on those who literally have no other option. There are a lot of challenges, though, when it comes to access, right? Location, target population. Does somebody need a phone to be able to access 211? Do they need to be able to get across the county to access the front door of an emergency services? Do you have too many people showing up, right, looking for assistance? Do projects out there on the line have staff that aren't trained, that don't have the necessary skills to help de-escalate crisis, to work on motivational interviewing, to engage in these problem-solving conversations that allow us to negotiate and explore alternatives to that person's homelessness in real time? Perhaps the operational guidance isn't clear yet. And I think this is something the state and with Stephanie and others, I know Christy and Mandy and others that have been working on with many of you, how do we operationalize a process where there's a clear line of communication between somebody who's in crisis to an emergency service, and then to that evaluation of whether or not we can assist them with a housing solution, right? So creating these workflows and accessibility is really a challenge that we're working to solve now, that all of you, I think, have been working on for many months. And so as we see more people seeking assistance, we need to make sure that we have greater access through mobile outreach. We need to have greater attention to creativity and problem solving at the front door. And we need to make sure that our overall system is accessible to the folks that need it most. In order for us to get to the point where we're able to assess need, folks first need to be part of the system. And so that is that access point. Once people access our services, whether that is in a tent up in the North Country, whether that is in a shelter in downtown Manchester, whether that's in their car in Keene, wherever it may be, we're now able to connect them to this idea that we're going to begin to collect the information and understand the unique needs that that individual family or person has, so that we can try to best strategize how to address those needs. In New Hampshire, right now, many of you were using what is called the COVID assessment, which was redesigned in light of the pandemic, that allowed us to really focus our resources on those with physical medical vulnerabilities that were related to COVID-19. Prior to that, New Hampshire was using the VI SPDAT or versions of the VI SPDAT as part of its assessment process. And then there's been this sort of intermingling of case conferencing that we're going to talk about more as well. Right now, I just want to make a note that we are working with the state and you all to redesign the assessment tool and process that you employ here, at least in the balance of state, to really begin to infuse equity and to really start thinking more creatively about how the information that we gather is relevant specifically to the folks and the populations that we see in crisis here in the state of New Hampshire and the balance of state of New Hampshire. So some of you have actually participated in focus groups. We've held focus groups with some providers. We've also held focus groups with individuals who had experienced homelessness in the state of New Hampshire in the past, trying to understand how we can best utilize assessment protocol that collect the right information at the right time about the right people, so that we can make the right choices about how to be targeted with our resource. But assessment is a process, right? For those of you who have been around for coordinated entry the last 8 or 10 years, there was sort of this idea that we were going to collect a bunch of information on a psychosocial or a VI SPDAT. It was going to spit out a score, and that human beings could be sorted on a spreadsheet based on their score, and that would tell us how we're going to end their homelessness. And I think that is ridiculous. I think many people think that is ridiculous. The idea that we can take individual, unique human beings, score them on a 2 or 3 page document, sort of spreadsheet, and think that we can solve homelessness is outdated and arbitrary. So we use assessment as a term of process, a term that includes that diversion effort, that housing problem solving, that ability to collect the most immediate information that we need initially to ascertain somebody's immediate health or safety, and then move forward with greater amounts of information as we need to understand what more. So for instance, a lot of communities will assess everybody the same way, regardless of what they're eligible for. So if somebody comes in and they are not going to be prioritized or eligible for a permanent supportive housing bed or unit anytime soon, then why would we spend 45 minutes asking them invasive questions about their deep personal histories just to get to a point where we can reestablish what we already knew to be true, that the questions we're asking are not actually helping us lead to a housing solution for those folks. So we want to think about how we can use a more trauma-informed, more nuanced approach to understanding people's needs and vulnerabilities, where if somebody is escalating towards needing a heavier resource, we escalate that assessment so we can understand better those vulnerabilities. Where that escalation isn't necessary, we are collecting information in sort of a phased way, including conversationally, so that we can work through how to best serve them without wasting our labor hour, our time on assessments that lead to nothing. And that does not mean that we're not going to have a scored assessment, that scores are a meaningless indicator or tool in our toolbox, but it is one tool in a larger toolbox of strategies and creative work that we can do to approach people who are in a crisis. So we want to make sure that our assessment process is not too intrusive or long. We want to make sure that these processes are client-centered and empowered and that promote equity. One thing that we know is that, for instance, is that people across different racial groups and gender groups answer questions differently based on what they perceive to be the correct answer, right? So for so long, if you ask questions about eviction history or income, our systems were specifically designed, or if they existed at all, to turn people away who had the highest barriers to housing. What we try to do now is make sure that we're using a trauma-informed approach that allows us to gather information that actively screens in those people with the greatest amount of vulnerability, and approaching those assessment processes with the nuance and with the connections required for people to give honest answers and for us to understand their lives prior to us trying to identify a housing pathway for them. So that includes training for staff. This is not a training on common assessment. This is a training on the big picture items. Anybody doing common assessment, anybody who is engaging with somebody who's coming off the street or in crisis needs to be trained with the necessary skills to do so. The old notion that frontline shelter staff should be an entry-level position that includes data entry and bed checks is the similar notion that has led us to not be able to end homelessness. We need to train up and invest in our staff, in our people power, if we're going to make real inroads in how we work with people at the front door of their crisis. So this is sort of a visual of what phased assessment might look like. This initial triage: are you safe tonight? Can we make sure that you're not going to freeze to death? Can we make sure you've got a hot meal in your stomach? Can you make sure that your children are safe tonight? We work on diversion. What is it that we can do to help you avoid homelessness altogether? Do you have friends or family in the area that we might be able to call that would be safe for you to go to? Is your landlord actually legally allowed to make you lock those doors tonight? Or do you have recourse with the landlord that we can help you negotiate to keep you in your unit for another 2 weeks while we work this out? Are there other ways that we can help you avoid homelessness other than just giving you a shelter bed or a referral? Then, as those efforts continue and maybe they're not fruitful yet, we're doing intake, bringing somebody into emergency services, providing that initial assessment or conversation, thinking about where they may be eligible, and then where we're recognizing that somebody is likely to need a longer term or more permanent or deeper resource like rapid rehousing or permanent supportive housing. We're going through a more comprehensive assessment to try to then be strategic about tackling the homelessness of those with the highest vulnerability. What I think this part of this slide says is that we're not going to solve homelessness for everybody that approaches with the money from the feds, and we're not going to solve poverty and everybody's life problems. Some people will certainly need more than we can offer, or we would like to provide them more than we can offer. But as we go through these assessments or this phased approach, we recognize that as that pool of folks becomes smaller, it better fits the resources we have, and there's going to be a group of folks for whom we're unable to provide deeper services. So when we're screening people, we want those tools to help us capture consistent information, help us identify service needs, but making sure that that is one tool in our toolbox, that we are able to use these other creative strategies in combination with this idea of scoring for severity of need or vulnerability and reflecting these assessment tools based on the local community. And it may be news to some, but there is no federally endorsed assessment tool. The VI SPDAT is not federally endorsed. There's no assessment tool that is federally endorsed other than a homelessness prevention assessment tool that is endorsed by VA and will likely be endorsed by HUD in the near future. So we want to make sure these processes are locally specific as we think about what our assessment tells us. But assessment isn't any good unless we can think about what it tells us about prioritization. So prioritization is then taking the information that we understand to be available to us and trying to apply a rule of thumb, perhaps, around who we need to serve first. And I think that idea of who we serve first is one of the most critical ones that I want to make today, in that we are not necessarily going to be able to meet the ideal resource needs of every person or family that approaches our system. But what we can do is focus on the most vulnerable people within the community and trying to solve their homelessness first. Once we do that, once we're able to really house those most chronically homeless, those most episodically homeless, those who have the highest barriers to re-entering housing, who have deep eviction histories or criminal histories or lower incomes, we can then transfer over time our resource pool to that medium level vulnerability group who still, while in need of services, has more opportunity to escape or to end their own homelessness than those who have the highest levels of vulnerability. So prioritization is not a tool, it's a policy. The community, the continuum of care, you all as a consortium of stakeholders in ending homelessness are the ones who decide what that policy looks like. In the state of New Hampshire, in the balance of state, you provide authorization, I'll say, to what we call the Continuum of Care Board, which is operated by a group of folks and stakeholders, including the state, who determine these types of policies, and that you all have the capacity to provide input on and to vote on at certain points in time. And we continue to think about the policies by which we're going to prioritize. So this is HUD's prioritization policy. It generally aligns with the state of New Hampshire, the balance of state, that we're going to first focus on those who are chronically homeless or longest periods of homelessness, homeless persons with disabilities and the greatest severity of needs, those who, so this is sort of tiered down, right? Those who have a disability but don't have the greatest severity of needs. So trying to think about who are the folks for whom that we need to put the most attention. And one of the challenges that we face is by both our practice as communities for many, many years, as well be outside of the control of the folks on the phone right now, but as a reality that we try to tackle, and that is the sort of distinction between equality and equity. Prioritization is unfortunately an unequal process, in the sense that we cannot provide everybody the same thing or the exact thing we'd like to provide them. So what we have to consider is how we infuse equity into our process. What is it that different folks need in order to be successful? If we give in a rapid rehousing program every family or individual a security deposit and 3 months of rent, we exit them, we are operating with equality and we are running poor programs. If you are a rapid rehousing provider and you are providing fewer or more limited services than your contracts and the federal government allows you to do, you're tying your hands. So what we want to try to do is promote processes that are equitable, that recognize that different people need different sets of services and subsidy and support and referrals in order to be successful in housing, and orient our prioritization around that, recognizing that the person on the left in the blue shirt does not need as much or anything to be able to watch the ball game, while the person on the right needs much more assistance in order to, in the analogy here, come out of homelessness. Another point on equity is that our prioritization policies and even HUD's definitions are often directly promote inequitable practice. So for instance, our institutional care settings are historically racially inequitable. And so we know that more folks, what we think of as BIPOC or Black, Indigenous, people of color, or of ethnic minorities, more of those folks are in and out of our jail and prison systems, have more interactions with foster care systems, have more interactions with institutional care settings, and therefore their ability to even trigger the definition of chronic homelessness, which is a very specific definition within HUD's world, they're less likely as a group or as a statistic to be able to be considered chronically homeless because they have institutional care settings that disrupt them that are based on other inequitable or historical racism that exists in communities that are interrupting a homeless episode and therefore making them less of a priority based on our prioritization factors than others. So as we redesign, as we think about the work that we're doing, we have to understand that we are not necessarily here to provide equality. We're here to provide equity. We're here to adjust our programs and services as a whole, but also on the individual level to make sure that it's meeting the unique needs of people in our community and the individual cases that we're working to support. And we can look at that for different groups, right? Families have different characteristics, different resources. Single adults have different characteristics and resources. Young adults or youth have different characteristics and resources when it comes to their overall vulnerability and ability to get out of homelessness. Victims of domestic violence who are survivors or fleeing domestic violence have a particular set of needs in terms of safety and anonymity and being able to support them in getting back into housing safely. And of course, the folks who are not yet homeless that are seeking prevention services have different sets of characteristics and vulnerabilities. So we have to look at what our different types of systems look like, what it means to prioritize in the city of Manchester, where we do have the largest number of encampments in the state or number of people in encampments in the state. That prioritization or our access and referral via those most vulnerable folks who are staying outside looks different perhaps than in rural parts of the state where we may see some people in the woods or encampments, but we also are going to see a greater prevalence of doubled up families and individuals and a greater level of a number of people who are in inhabitable housing situations and other things like that. So our community characteristics and the characteristics of the people who live in it help drive how we prioritize our resources. But we don't want to only target very specific disabilities. There are fair housing issues with that. It is a combination of disability, of other factors such as housing history or lack thereof, whether or not somebody's had a lease in their past, whether they have evictions, whether they have income or have been in an institutional care setting. All of these contribute to whether or not somebody has the capacity or likelihood of being able to end their homelessness with lighter touch assistance or with a deeper subsidy that we provide. So in our common prioritization strategy, we see this sort of static list, right? Where nothing changes. You score a 22 and you are now going to be for PSH regardless, right? And what we see is that we get long lists of people who are waiting for a resource that doesn't exist. So what we're trying to do is move away from what you see here as sort of a static process where a single score or set of information dictates what we're going to offer this individual or family for their housing solution, and actually work with people in a more dynamic way. And we call this dynamic system management. It is a wonky TA federal type term that you don't have to know, but the idea is that we adjust who we prioritize, not based on a score, but based on who we have in front of us, where if somebody is vulnerable and comes in today, and we are going to say, okay, you're likely to need PSH, and we're going to start looking for slots. If somebody more vulnerable with higher risk and higher morbidity related to their homelessness comes in tomorrow, that person would likely get the slot first. So it is not a waiting list. It is a dynamic process that allows us to make adjustments as we go. Again, it is inherently unfair because we don't have resources, at least the ideal ones, to serve everybody that we would like to serve. So we're looking for this ongoing dynamic system management process that allows us to prioritize people based on the pool of individuals who are currently in homelessness. So we want to make sure that our housing programs are filled by the people who need them most, right? That we're serving those folks who are highest need first, and recognizing that there's going to remain a group of lower vulnerability or mid-level vulnerability individuals and families that we simply don't have the money right now to serve, at least not in the way that we would like to. And so this is sort of the way that it's worked before. The resources tend to go toward the folks in the middle of the pack. Our oldest, sickest, longest term homeless folks are waiting on lists. This 11 to 13 on a VI SPDAT, we say that means permanent supportive housing, so we're not going to offer them rapid rehousing because we don't think rapid rehousing can do it. While we also have to acknowledge that in many cases our rapid rehousing projects are not operating under the full flexibility they're allowed, and so are shortchanging themselves. And we end up with these tiers where those 11 and 12s and 13s on the screen are only becoming sicker, older, more vulnerable, and being homeless longer, while folks that have in this schematic more capacity to end their own homelessness or are less vulnerable in their homelessness are being served. And so we create these cohorts of groups. We essentially create, a glide path to chronic homelessness for groups of people because we refuse to provide a lower level of service or a shorter term engaged service than what might be ideal. So what I will say out loud, and I will stand by this, is that rapid rehousing is one of the most underutilized resources in this country right now. Projects that are only taking mid-level vulnerability folks or folks that have income and have easy pathways toward permanent housing and are going to subsidize them for a few months and exit them are probably doing well by the wrong people. You're probably serving more people not as well and not necessarily contributing to an end of homelessness for the most vulnerable. Our rapid rehousing projects, both CoC program and Emergency Solutions Grant program, need to operate within the flexibilities that we allow within the practices that have been proven to work in rapid rehousing, and we could do training all day on that around how you effectively build rapid rehousing projects to meet the most chronically homeless folks' needs. And then also looking at how our permanent supportive housing projects and our rapid rehousing projects interact. I know there were some move-on vouchers in New Hampshire this year. It's a prime example of the ability to serve people well in rapid rehousing while actively looking for a longer-term, deeper subsidy that can be more permanent for those folks that need it. But we can't get stuck in this zone where we're leaving out our 11, 12s, and 13s just because we don't think we can serve them. We have to be looking at what is available now and how do we adjust our programs to make that available resource best meet the needs of the clients who need it most. And so we see here, again, that same sort of tiering. What we're trying to do is move that bar where the most vulnerable folks are assisted first. As we are able to assist those with the highest level of vulnerability and the highest barriers, once those folks are off of the streets, out of shelter and in housing with the supports they need, our resource pool is then adjusted. Our prioritization is adjusted to now work toward the left-hand side of your screen and be able to serve people with those lower levels of need or vulnerability that we may not be able to have been able to serve before. Again, this relies on exceptional nuance and thoughtfulness around how we use the very limited permanent supportive housing slots that we work with, exceptional attention to good rapid rehousing practice, and exceptional employment of diversion and problem-solving techniques. That is the only way we're going to end homelessness. And I will say, too, for our transitional housing providers on the line, many of you, I think for many years, have felt like HUD and the world pushes out transitional housing, and that's generally true. Transitional housing has a place in systems, and it's a highly specific client choice-based role in ending homelessness. But keep in mind, as we think about prioritization and some of the nuance to HUD, once somebody goes to transitional housing, they are no longer eligible for any of these other HUD permanent housing resources. So if you're a transitional housing provider, you need to be fully on board with being able to facilitate permanent housing exits directly from your projects, because by being in your projects, at least for the HUD homeless dollars, your clients are no longer eligible to be connected to those dollars. So we have to be thoughtful about how this prioritization works within us. It doesn't mean that folks that aren't prioritized aren't, referred or they're ignored. We need to look for those diversion techniques. We need to look for those landlord networks we can connect them with. We need to give them those referrals into employment supports, but we may not be able to serve them now with a housing resource because we simply don't have enough. Oftentimes, we have to employ case conferencing as part of this overall process, right? So we have to think about how additional information can work its way into our considerations that are beyond an assessment score. And it gives us the ability to communicate as groups, whether in your RAPs or within your continuum of care, to really think about, okay, on paper, Doug, it looks like they need all of this, but in reality, Doug has these supports that I have been working with Doug and I've recognized. Or on paper, Doug looks like he's going to be doing just fine. So I mentioned my father was homeless in Manchester, and on paper, my father would not have looked very vulnerable on a VI SPDAT or whatever it might have been. He had one primary challenge when it came to his homelessness, and that was his alcohol use. And it was not his use of alcohol; it was the fact that he would lose his job because he would show up either drunk or hungover, and he was kind of a jerk, and he would lose his job, and then he would go through that cycle. It wasn't that he was throwing parties; it wasn't that he was blowing his budget when he had money on alcohol. It was that he was losing his job all the time. And so on paper, my dad looked one way, and in the real world, the considerations for whether my dad should have been housed, which he wasn't by anyone in the city of Manchester because he was turned away for being an alcoholic. The consideration for whether he should need housing is different for him on paper than it is for somebody who may have connected with him and understood his needs and be able to use case conferencing and discussion to inform the community about what that looked like and about what type of supports he might need, which turned out to be much less intensive than one might have suspected for him to keep his housing. So we don't want to just create numbers and X's, right? They're this number, they get this intervention, because we don't have that direct connection between the number of people who score in that vulnerability range and the resources that are there to meet that need. So what is the best use of our currently available interventions and resources that meet the needs of the people who need it most right now? And how do we use our prioritization policies, our assessment policies, and our case conferencing to make those adjustments, to define how we're going to move forward in a very sort of dynamic way that allows for a clear process that's transparent and that allows us then to make those referrals. And I'm moving quickly because I am watching the time. You will get these slides. We're trying to make those referrals to the finite available slots that we have in front of us. So part of that means that we're including those eligibility considerations as part of assessment, making sure that there's eligibility, thinking about navigation from the point of view of how folks are getting document ready or that they're confirming that they qualify for a given program. We heard some really wonderful feedback from some folks who had experienced homeless in the state who reported filling out 40 or 50 different applications for housing, repeating the same information, the same trauma-inducing sort of spilling out their livelihoods on these forms that get faxed and sent out to black holes, and they never hear from anybody until years later, and then they're told they're on a list but have no indication of how long that list is going to take to get them housed. We need to be thinking about how our resources and the way in which we identify folks who are eligible and prioritize for those resources can be systematized so that if I approach you in county or program, you're not asking me all the same information that somebody asked me 2 days ago in a different part of the state or a different program or the shelter down the road or the outreach team, just continuing to re-traumatize all of the challenges that I faced in my life. So thinking about how overall prioritization and eligibility for services line up, understanding the nuances of eligibility between permanent supportive housing, dedicated chronic beds for permanent supportive housing, rapid rehousing, our young adult projects, what are the criterion for transitional housing projects, and how do those criteria fit into the larger strategy, not just you're coming into transitional housing, you're going to get sober, and we're going to make you call and sign in every day, and you're going to do your chores. That doesn't end homelessness. What ends homelessness is helping to facilitate a movement toward housing options that fit people's needs. One of the truths is that folks that are chronically homeless and have the highest vulnerability are generally where our PSH projects should be focused. What's also true is we don't have enough PSH for those vacancies. So our rapid rehousing programs on the line need to be able to work flexibly with those higher need populations. Right now, rapid rehousing allows for 2 years of assistance. You can create written standards with the CoC that heavily subsidizes people. The veteran space has what's called shallow subsidy now that allows for a quasi-permanent rent subsidy for veterans that can cover 50% of their rent with light touch services. If you, again, are operating a program that is designed as PSH to meet the most vulnerable, you need to be ready to provide the services for the most vulnerable people. You are the ones providing the services for the folks with the most mental health challenges, the lowest incomes, the deepest sobriety issues, the deepest criminal history. That's your job. If you're a rapid rehousing provider and you're giving everybody 3 months of assistance and a security deposit, then I think it would be a very prudent strategy to revisit your policies and program design to better meet the needs of more vulnerable people. Otherwise, we're never going to get there. We simply don't have enough permanent supportive housing. And using the flexibilities that we have in a rapid rehousing model, using shared housing, using the ability then to bridge folks into longer term supports like PSH or like housing vouchers that have multi-year waiting lists, right? Thinking about how our programs can be adjusted to meet the needs of the community rather than the community or the people that we serve trying to adjust to meet the needs of our programs. So this is a real-time process. This is what Court Entry is designed to do. It is not designed to be stagnant. It is not designed to be perfect. It is not designed and will never be able to give everybody the ideal resource for which we think they need, but it is designed to really focus on those folks that need our help the most and to use more creative strategies that allow us to focus our labor hour, our diversion efforts, our problem-solving efforts, our creative mediation strategies, our trauma-informed motivational interviewing to help navigate people away from homelessness and towards something other than literal homelessness. We are not going to solve poverty. If you want to solve poverty, this is probably not the job for you. We're not going to solve sobriety issues. We're not going to solve mental health issues. We are here to solve homelessness. And so that becomes our laser focus. And that is the focus on what this dynamic process looks like. So in referral, we think about how those navigators can be used to help figure out who's document ready. We can think about how different housing slots align not only with what somebody may need, but what they want, what their housing preference and geography is, whether they have children, whether they need a larger apartment because they have a pet they're not willing to give up, whether they need to work with a landlord that allows for a past eviction record, whether we need to link them to somewhere that's accessible to public transportation or the VA medical center or the hospital. All of those pieces come into reducing the barriers of entry for those who have the highest barriers to leaving homelessness on their own. Part of that is navigation, making sure that we are working on document readiness as we go, accessing different services outside the system, making sure that we have a touch point so we're not losing people in the system. Part of that touch point issue is really going to be focused on HMIS in the coming months, everybody's favorite topic, and then building in accountability for ourselves and our community and making sure that we aren't kind of glossing over the challenging realities that we face as a community and making sure that if referrals happen to PSH, that you as a PSH provider are serving the hardest to serve and getting them into housing. That if you're a rapid rehousing provider, that you're adjusting your subsidies and services and length of time of support to meet the individual needs of the person or household and not the project. And that we're not rejecting people. Landlords can reject people. Community partners can reject people. We, homeless system providers, do not reject people based on vulnerability. We actively seek to bring in the most vulnerable because that's the only way we're going to be able to house the most vulnerable and allow our resources to transfer to those lower vulnerability groups over time. So I think, and I've been trying to watch my clock, I am exactly at 2 o'clock, and I'm going to pause a moment because I just threw, I believe, 60 plus slides at about 100 people on this line, and I need a sip of water, and I'm going to turn it over to Stephanie to see if she has been able to take a look at the chat, and I'm going to do the same as I get my sip of water.
I think I've only seen one question. I encouraged everybody to write their questions down for the end. So if you have a question and you'd like to voice it out loud, please use the raise your hand function in the reaction function of Zoom, and we can get your question, or you can put it in the chat.
While we wait, and I know we're over time, so folks have to hop off. We will end soon, but this is recorded. There was a private chat that came in just acknowledging client choice and preference. And I really want to highlight that notion that what we think somebody needs is not necessarily, and often is not, what they want or need in their lives. We may think that somebody should live in a certain place, or with certain people, or without certain people, or while doing certain things or not doing certain things. That is not our job. Our job is to work within the choices and preferences and goals of a given client or household, and look for ways in which we can promote some sort of sustainable housing solution. That may mean they're severely rent burdened. It may mean that they are actively using. My dad as my example, which is my real example, and I don't make anything up with my dad. He died this year. He drank himself to death. And him getting back into housing after going in and out of homelessness for a period of time, for many years, had nothing to do, him getting back into housing did not solve his alcoholism. He drank, close to a gallon of vodka a day for his final year. He was very sick, but he died in housing. He didn't die on the street. And his choice, or his goal, was not to get sober. When it was his goal, he tried and he was unable to do so. And that happens to a lot of people. But what we need to acknowledge is that the goals that different people have, or the capacity to achieve their goals, may be different than ours. And so thinking about providing that choice of where people want to live, with whom they want to live, what goals that they want to pursue. Maybe we can continue, someone can continue with habits or life choices that we don't agree with, but if we can find ways to help them sustain their housing, like my father, where his landlord, there was a mediated agreement that his landlord would directly take his rent out of his account every month. And he never missed rent, and he ended up on his couch and passing away at the age of 57 years old. But he didn't lose his housing for his alcoholism, because they negotiated a creative way to get to that. So thinking about how different choices are made and whose choice it is that we're supporting, and making sure that we really support the choice of the client, because they are human beings. Any one of us on this call could fall into homelessness. A lot of folks are a paycheck or a health crisis away from homelessness. And we would want to have our own self-determination and empowerment in trying to end our own homelessness with your support, should that happen to all of us. So I was just bantering for a minute there, Stephanie, as we see if there's anything else that would be helpful in this chat.
Looks like we have one person who raised their hand. Will with Crossroads.
Okay. You should be able to unmute. Let me check on you for a second.
I'm here. So first of all, Doug,
there you are. Hi, Will.
Doug, thank you so much for that great presentation. And I'm the new executive director of Crossroads Housing, and really new to the whole world of homelessness. And so I'm trying to excuse the kind of the maybe what may seem like well, I guess there is no stupid questions, as they say, but. So the question for me is, as I listen to you, and maybe there's an obvious answer to this, but how do you, so we are really a privately run organization. We get about 3/4 of our funding through private donations. And as I was listening to you, the question that popped into my head is, how do you balance coordinated entry with an kind of statewide or region-wide, with organizations that have boards that are dependent on, in our case, 3/4 on donors for 3/4 of our funding, and how do you balance that with the need for this policy initiative around coordinated entry, and which to me makes perfect sense, but I think that there's an issue of kind of a question of local control versus a more broader coordination of resources and a collaborative sharing of resources and so forth. So I don't know if I'm expressing myself well there. Or...
Yeah, and I think that's where we get. That's part of the discussion now, at least, in parts of the state around these regional access points, right? How do we create policies that generally are aligning for what our goals are, while also allowing for some of that local control, so that what's happening way up north and what's happening, down near the seacoast are two different realities, and allowing for that local control. I think from an organizational perspective, Will, any organization can be part of coordinated entry, and part of, I think, the discussion is identifying what is the unique role that you play in this larger system versus other projects, right? What are the services you provide? What's your target population? What are the unique assets that you bring to this system? And then how can the coordinated entry process identify households who would benefit most from your services and work with you on that referral process? So because you're not funded by HUD, you're not bound by coordinated entry, but because you are an interested stakeholder in the continuum of care, you have a voice in how that process unfolds. And so taking a look at the Crossroads mission, the type of clients that you're serving and the types of services you're looking to provide, and then working with coordinated entry to identify, okay, with that in mind, how do I position my role into this system? What we want to avoid, to the extent we can, is a client just shows up at Crossroads, and because they showed up, you're going to help them, right? Like, they're in. And so I think it's a give take. You are providing a service to the overall system that is clearly defined, and that the system understands that service you provide for those households that need it or want it. But also, should clients just show up, or somebody needs help that you're not either able or willing or within your specialty to provide services for, that you also have that direct connection to another emergency capacity that then moves them toward kind of whatever might work for them. So I think there's this balance between organizational mission with a board, right? And funding streams and local control, and then all sort of being on the same page about what we're trying to achieve. What we're trying to achieve is really trying to target our assistance to those who are most vulnerable. Because I think if you do that for a couple of years, and you can really focus on those chronically homeless, longer-term homeless folks at the highest levels of vulnerability, all of our jobs get easier over time, because we start to reduce the length of time someone's been homeless over time in the general pool, because we're tackling those hardest cases. So I always advocate for that at the front end. But where you're providing a service that is unique to you geographically, so service-wise, whatever it may be, then that is a conversation, I think, with the continuum, with the court entry teams, to figure out, how do you fit? What are the referrals that are appropriate for Crossroads versus not appropriate for Crossroads? Say, and I don't know much about Crossroads, but one of the, I think, misunderstandings out there is that there's no role for sober environments, right? There's no role for environments with structure. And so there's a difference between, we want to practice housing first, in the sense that we don't want to limit folks who have sobriety issues, say, from a project, but we also recognize that there are people who want to be in recovery and who need a structured environment. So how do we create different options for those people? And I don't know if that's true for Crossroads, just as an example. If you are particularly good with employment services, then maybe there's some targeting criteria for folks who are employable, or express interest in employment. And now, Crossroads is a place that promotes employment services, or whatever that specialty service is. So I think it's a longer conversation, Will, but there's a place for you and your team in this system that I think allows that autonomy and control, while also contributing to the larger goal and portfolio of what we have to offer folks that are in crisis. And Stephanie, feel free to chime in here too. Yeah.
Yeah, I wanted to just add in. So Crossroads receives some funding through the state and through the federal government, but I think it's a great question, because so many of our providers and programs here, and so many of the people on the call today, do have a mix of funding. And so they have their requirements through HUD and through the state, but then they have, their boards and everyone else helping them get the rest of their money. So balancing, meeting all the requirements, but also making sure they're making their donors happy and all of that too. It's quite the balance. So I think that's a really great question, and something that, we all want to continue working together on, to make sure that, because as Doug mentioned in the training, there are some flexibilities with these different lines of funding through the federal government and the state. And then there's some things that we absolutely have to stick to. So helping balance and making sure we're flexible where we can, to make sure that you're getting, the needs met for your board and all of that. Definitely, I know it's a difficult balance to strike, but we're all here to work together and try to do that as best we can. We know that, as Doug mentioned earlier as well, these federal and state programs can't fund everything needed. And so everybody's working really hard on how we fill in those gaps. So I thought that was an excellent question, and I hope we can keep working together on that.
Just one final note for everybody, and I think it's relevant to Will's question, your response, Stephanie. You know, I just presented 60 slides that make it sound like homelessness has this sort of utopian easy answer, and we're just going to like create graphics and everybody's going to be hunky dory. This stuff's really nitty gritty and tough when we get into communities, and it's going to be nitty and gritty and tough in the coming months as we work through different protocol. I'll be supporting this, continuing to support the state on general planning around these issues and having conversations with many of you, I would suspect. I also have a colleague, and I've been involved too in the veteran space in New Hampshire around veteran planning efforts. There's youth planning efforts. What we try to do today is create an established foundation. But I just want to acknowledge that not only is the system nitty gritty and tough, but the day-to-day work of working with people in crisis and all different levels of need is really difficult work. It's particularly difficult a week before Thanksgiving and coming into the holidays and the cold weather, and just watching the chat and seeing things, folks jumping off here and things drying up. Really appreciate the time, and not only the time, but the commitment, because I work with a lot of communities across the country, and I see a lot of hardship, and I see a lot of really cool work happening out there. I think there's a lot of capacity in the state of New Hampshire to make real inroads. I'm from here. I understand the dynamics better than most places I get to work in, which is helpful. But you all do incredible work, and I just want to acknowledge that me presenting this sort of HUD, TA, federal utopian language, I fully recognize that the nitty gritty, trauma sort of inducing, stressful work that you all have to take and do every day is by far the hardest job of anyone on this call. I certainly have the easiest job. So I just want to acknowledge your work and also promote everybody be thinking about self-care. And that's just a side note for me, that these are really difficult times for our clients, but also for our staff, and really trying to make sure that you all are staying and being well within the really challenging dynamics that we face right now in this country, in the state, in the cities. Homelessness is an unacceptable part of our social fabric that we need to end, and it takes a lot of hardship to get there. So Stephanie, I've been watching the chat. I don't see any other burning questions, so I think we could probably move to close out, unless someone, if anyone had raised their hand. I couldn't see from my end right now.
I'm not seeing anything else, Doug. I think we're okay to move forward to close.
Great. So we are planning additional trainings for folks. We'll announce those as they come. There's going to be a lot of conversations about coordinated entry in the coming months. In the meantime, we will send these slides and this recording out to you all. You have Stephanie's email. If you need anything from her and she can connect with me, I'm happy to be a resource where I can. And just I want to wish you all, a happy, blessed, safe, and healthy Thanksgiving next week for yourselves and the folks that you serve. And hopefully we'll see each other before the holidays, if not holiday season as well. But thank you all for your attention during this busy time. It's very much appreciated. Thank you, Stephanie, and the folks at VHS for helping to support this, and for giving me a little bit of freedom to work my slides and my soapboxes. And I hope you all have a great rest of your, it's only Monday, that's remarkable. Great rest of your Monday, and we'll talk with you all soon. Thank you.